Hello, welcome to Microlearning Module 3, Overview of Atrial Fibrillation and Coagulation Disorder Medications. My name is Carrie Reynolds, and we are here with Tracia Oshana, who will be leading us through this particular module.
Okay, so when somebody has atrial fibrillation, we usually begin with the beta blockers, and our prototype is metoprolol. Our goal here is to control someone's heart rate. So metoprolol is specific, so it's blocking the beta-1 receptors in the cardiac tissue, and our goal is to reduce the heart rate and therefore reduce the force of contraction and reduce the workload on the heart. So it is really important to then make sure you measure someone's heart rate and blood pressure before giving this medication. If the beta blockers are not as effective, or if the client needs a second medication, we consider calcium channel blockers, and the prototype is diltiazem. So we are blocking calcium from entering the AV nodal cells, again, slowing that conduction, prolonging that refractory period, and reducing the workload on the heart. And again, don't forget to monitor that blood pressure and heart rate prior to giving this medication, and most definitely after, to make sure someone is not experiencing any bradycardia or hypotension. Another option for atrial fibrillation is amiodarone. This is blocking potassium channels, so we are prolonging action potential and really reducing that repolarization. And we're disrupting those arrhythmia circuits, so we're slowing down that heart rate. Some side or adverse effects to consider is hypothyroidism, so monitoring a TSH is very important. But also you can develop this hyperthyroidism that's drug-induced, so again, keeping close eye on the TSH. Even though we're trying to prevent arrhythmias, these medications can cause arrhythmias, especially if somebody experiences significant bradycardia. So again, monitoring that heart rate. With amiodarone and calcium channel blockers, no grapefruit or grapefruit juice. So it's really important to include that in your client education. When somebody has atrial fibrillation, not only are we trying to control the heart rate, but we're also trying to reduce the risk of blood clots. So we need to consider anticoagulants. These days, our first choice is abixapan, which is Eliquis. And again, with any anticoagulant, our biggest concern is bleeding. Abixapan inhibits factor 10A, which we're stopping the conversion of prothrombin to thrombin, which then reduces the fibrin clot formation. This is, again, very selective to that factor 10A, so it doesn't affect your platelets or other clotting factors. Even though there is a risk of bleeding with abixapan, the risk isn't as great as if somebody was on warfarin. Warfarin, also known as Coumadin, this inhibits vitamin K regeneration, so therefore it's affecting more clotting factors, 2, 7, 9, and 10. So the risk for bleeding is greater. This is why we're starting to move towards abixapan and move away from the warfarin. With warfarin, we need to monitor the PT-INR, and anyone who's on it, their INR should be between 2 and 3. If they are super therapeutic, above 3, you may find that vitamin K, the antidote, is ordered, so to prevent any bleeding. Thank you.